Next, we have Dr. Ambika Shetty. She's cataract and anterior segment surgeon and medical director of Gitanjali Eye and ENT Hospital, Trivandrum. She'll be talking to us about management of intraoperative floppy iris syndrome, taming the floppy iris. Over to you.
A warm good morning to all of you. So, small pupil is already a little kind of a challenging situation for cataract surgeons. But a small pupil for whom sphincterotomies don't work, for whom mechanical stretching also doesn't work. So, this is the situation of the floppy iris. So, today we'll be speaking about taming the floppy iris. So, intraoperative floppy iris syndrome is characterized by iris billowing, that is, the iris starts fluttering like a parachute in a breeze. Then there is intraoperative miosis, there is iris prolapse through the phaco and side port incisions. So, the reason being, usually patients are on alpha blockers. The most common drug that is attributed is tamsulosin, which is an alpha 1A specific blocker. So, this actually weakens the dilator muscle, and there is unaffected constrictor muscle action, which is responsible for the floppy iris. So, if you look at the Indian population, around 4.78% of our cataract patients are on tamsulosin and other medications which can cause IFIS. So, the range of complications can vary from just a mild iatrogenic iris injury, a severe iridodialysis, hyphema, and commonly PC rent and vitreous loss. The risk is higher if one is not prepared. So, before starting the surgery, it's very important to classify whether the case is mild, moderate, or severe variety. This can be done easily by assessing the preoperative dilatation. So, it's important before you start surgery to anticipate. So, in our clinical practice, we have seen that some patients who are on Ayurveda medication, they say they're just on herbal medication for prostate problems. So, even they have developed IFIS. So, it's important to take a very thorough history. Sometimes patients may not reveal that they're taking herbal medications. And during the clinical examination, it's important to check the pupillary reaction and what is the preoperative dilatation. It's very important to have a standard protocol. So you have to train your counselor and OT staff regarding how to manage these cases. These patients have to be counseled that there is a higher risk as compared to regular patients, and also OT staff have to be prepared with the extra steps, whatever is needed for this particular case. So, when you start the surgery, it's important to to have well constructed wounds. It should be watertight, and the entry should be anterior to the iris root. Then the next thing is, before starting your capsulorhexis, inject adrenaline into the anterior chamber to maintain the intraoperative mydriasis. The capsulorhexis size should be adequate, and if required, you can make it below the pupillary margin. So, just inject small pulses of fluid when you're doing hydrodissection, and you can inject it gently and tap the nucleus to decompress and gently rotate the nucleus. So, this is the most important step to prevent iris prolapse. And when you're going for nucleus emulsification, use minimal vacuum. You can it's better to prefer trenching methods, and also if you know mechanical shop that works better in such situations. Whenever the iris prolapses out, inject OVD and reposit the iris back. It's also important to lower the bottle height as compared to a regular case. So in case the iris prolapses out through the side port, you can reposit the iris back from the adjacent wound. Then again inject oculoviscous device and then proceed with the surgery. While injecting the phaco probe, it's very important to be gentle and enter in a very careful manner so that you don't engage the pupillary margin. And the emulsification should be done at the level of the anterior chamber or slightly in the capsular bag. It should not be directly at the pupillary margin because you will increase the turbulence over there. So the nucleus pieces should be gently emulsified. So when you are going to inject the intraocular lens, ensure that you inject the cartridge very gently. And while doing the cortex aspiration, ensure that you are visualizing the cortex and then doing the aspiration. So Muscat and Bellani have shown that when we use topical atropine sulfate and intracameral non-preserved epinephrine, around 90% of cases have excellent pupil dilatation without any signs of IFIS. So preoperatively, medications such as atropine, homatropine, cyclopentolate have been used to maintain the dilatation, and NSAIDs also have been used. This also contributes to maintaining intraoperative mydriasis. Intraoperatively, you can also use adrenaline, phenylephrine, and lignocaine. So Dr. Steve Arshinoff has described a tri-soft shell technique for IFIS in which a viscoadaptive viscoelastic is injected first. This coats the corneal endothelium and also it pushes the iris down. Next, a viscoadaptive viscoelastic is injected to maintain adequate volume in the center of the anterior chamber. This also blocks the prolapse of the iris. And then the third is the layer of fluid, that is the xylocaine phenylephrine or BSS. This actually is injected just in anterior to the lens capsule. This provides a space where there is least resistance to capsular excess. So in a situation, if there is progressive pupillary constriction, you are not prepared for IFIS, and you notice, oh, in between the surgery, the pupil is constricting. So it is best to just stop phacoemulsification at this point of time and then shift to a safer technique. You can inject a mechanical pupil expansion device and proceed with the technique. The rest of the surgery would be like a regular case once the pupil gets expanded. So in this case, I have used BHEX to expand the pupil. So in a case where the anterior chamber is very shallow, the pupil dilatation is very minimal, like 2 to 3 millimeter, and also a hard cataract, it is always safer to use iris hooks. In this case, I have used 4 iris hooks, and actually since it was a very dense hard cataract, I have planned a SICS in this case. So we use a diamond shaped configuration to minimize engagement of the iris while when we insert instruments through the main incision. So once the wound is extended, the nucleus is gently prolapsed into the anterior chamber. It's very important to ensure that during nucleus delivery, we don't engage the iris. So when we insert the vectis, it's important to visualize the vectis throughout and then deliver the nucleus. So the take-home points are, it's very important to elicit a thorough history and check if at least in the past the patient has used any alpha blockers and anticipate IFIS before surgery. A preoperative prophylaxis actually reduces the complication rate to 0.6%. So it's very important to use the preoperative prophylaxis. OVDs are very helpful in preventing iris prolapse. It should be used judiciously. Hydrodissection and hydrodelineation are two maneuvers which present more risk of iris prolapse. So that is why it's very important to be very careful during these steps. Thank you.
Thank you, Dr. Ambika. I think that was a very beautiful demonstration of management of IFIS. I would just like to add 2 points to this. One important point is, like, if you're beginning a case, you're not sure whether it's an IFIS, or if you know that there are subtle signs of IFIS and you see a small pupil, please don't go and stretch this pupil, because if it is an IFIS, it is going to worsen the further management. If you feel it's a small pupil and you need more visualization, either please directly use hooks or a ring. In my personal experience, what I felt is, when it comes to IFIS, the B-hex is a very, it's a very flimsy and thin ring. It is just 0.1 mm thick. So if it is a moderately severe IFIS, it becomes a little difficult to place the B-hex into the iris margins. A very severe IFIS, it's a personal experience, I feel the Maligan ring does better, because it hooks on better and stays better and keeps the iris better into the place. And second point that I wanted to share is, as you were demonstrating in your video, one tip that I've learned from another surgeon is, in between the case, if you feel that from the side port your iris is popping out near the dialer or your chopper, what you can do is you can come out and you can actually hydrate that wound. Because when you hydrate the wound, the tendency of the iris to come out reduces from that end. And also, if you know that it is a case of IFIS, like the other eye you have already had IFIS and you know this eye you're going to face IFIS, then another trick is, the incisions that you made should not be limbal, it should be slightly inside. Then there is a less chance for the iris to prolapse out. These are the 2 points.
Yeah, that's true. It's very important to make the entry also just in front of the iris root. That's a very important step. And as you said, the B-hex, it doesn't work if the pupil dilatation is very small, like 3 to 4 millimeter. Or
yeah, and what happens is, because it's a floppy billowing iris, placing the hexagonal edges becomes difficult to place in a very floppy iris.
Yeah, if it is dilatation is too less, then it's difficult. Yeah.